So good afternoon, everybody, and welcome to this first POS webinar. For further proceedings, I'll hand it over to Dr. Abhijit, Secretary of POS. Over to you, sir.
Thank you very much, Ashok Sham sir, and welcome everybody. This is a very exciting time for us. And on behalf of the POS, I welcome you all to the first webinar that we are hosting on behalf of the POS in this academic year. As you all might be aware, we have been going through some very trying times because of the COVID situation, and yet it is remarkable how people have been utilizing this time to keep their swords sharpened through continuous online learning, through reading, and through participation in educational events. And I think it is apt to commend Dr. Ashok Sham, who has been on the forefront of making this happen in our country and for organizing these webinars. It's very difficult to imagine how busy he is organizing these webinars, not only national but international webinars as well. So thank you very much, Ashok Sham sir. We really appreciate it. Uh, I would like to Sorry about that. I would like to welcome you all to this webinar, and this is first and foremost, I would like to express the sincere um, regrets from Dr. Narayan Karne, our Honorable President, sir, who is unable to attend this webinar because of health issues, and he has conveyed his best wishes to all of us. This is our first academic event where we are all meeting together. And on behalf of the Executive Committee of the Pune Orthopaedic Society, the President-elect, and the entire Executive Committee, I extend a very warm welcome to you all. We have never had the official and the formal change of guard from the last executive committee because we did not hold the POSAC, our annual flagship event. And this is for the first time, I believe, that many of you will be introduced or reintroduced to the executive committee. And this slide will reintroduce you to the committee this year. I have the distinct honor of serving as the secretary of the society under the leadership of Dr. N.J. Karne, who is our president. The outgoing executive committee was of Dr. Srinivas Shintri, who was the president, the past president, and Dr. Sanjay Patil, who was the past secretary. And they did an exemplary job last year. And despite all their hard work and their um, dedication and their commitment to organizing a fantastic POSAC, we had to unfortunately call it off at the last moment because of the turn of events. Our president-elect is Dr. Chetan Pradhan, who is a very dynamic president for us in the forthcoming year. And I am very honored and very kind of fortunate to work with a very dynamic executive committee comprising of Dr. Swapnil Bhise, Dr. Yogesh Khandalkar, Dr. Nilesh Jagtap, Dr. Rajiv Niravne, Dr. Abne Sir, Dr. Rahul Zanzurne, Dr. Shailesh Hadgaonkar, who are always on their toes to be of any help in taking our cause forward. Dr. Ashok Sham sir is, needless to say, he is always ready to help you out with any organization and anything that is required in terms of conducting a webinar and updating our website and also keeping us abreast with the latest technology. And then our co-op members, Dr. Sachin Zadhav and Dr. Nagapurkar, who are also a very dynamic and a very valuable addition to our profile of the executive board. I would also like to mention the speakers today. Dr. Anup Bansode will be speaking about basic considerations in distal radius fractures. Dr. Shailesh Patil on basic considerations in carpal fractures. Dr. Satish Mane on basic considerations in hand, such as metacarpal and phalangeal fractures. And Dr. Nilesh Darawde who will be speaking on basic consideration in nerve compression. Special thanks again to Dr. Ashok Sham. And a little bit about the POS. The Pune Orthopedic Society is of the society, by the society, and for the society. I encourage all those who are viewing this webinar and who are not yet members of the Pune Orthopedic Society to please consider becoming members. Your association with the society will go a very long way in advancing academics, camaraderie, and science and knowledge. This year, we thought of having the motto of inclusion, involvement, and thereby evolve. So we will go all out in providing a platform to young talent, to our colleagues who are doing exemplary work, and we need to showcase their work to the world and to the fraternity. So please come forward, and we will be reaching out to you to include you, to involve you in academics so that you can share your experience, your acumen, and your knowledge with all of us. And we need to hear from you, all those who are more often than not silent spectators. I'm sorry to use that phrase, but those who kind of prefer to attend are also doing fantastic work, and we will be providing a platform to you all. So please reach out. We need to hear from you. We need to have you on board so that we can advance collectively as a fraternity, as a brotherhood. And we will collaborate with you to make that happen. Without further ado, a very quick introduction to our speakers today. Dr. Anup Bansode is a graduate of Aurangabad, and he did his postgraduate MS orthopedic training from Sancheti Institute for Orthopedics. And then he went on to do a fellowship in hand and upper extremity surgery. He has published some. He is a young, dynamic hand surgeon and an upcoming star. Dr. Shailesh Patil is an established hand surgeon who practices in Hadapsar. He is a senior consultant at Noble Hospital. He has completed fellowship in hand and microsurgery, is an accomplished surgeon, a very dear friend, and excellent academician. So please welcome Dr. Shailesh Patil to speak to us. Satish Mane is again a very young and dynamic hand surgeon, a very promising future leader in the field of hand surgery. His special interests include brachial plexus and microvascular reconstruction, and he has contributed to advancing science through his many publications in a very promising way. And we have a dear friend, Dr. Nilesh Darawde, who is a consultant hand surgeon at the Dinanath Mangeshkar Hospital and the KEM Hospital. And he is a very accomplished hand surgeon, very competent in microsurgery, and he has trained at the Ganga Hospital for his FNB training, and he will be talking to us about considerations in nerve surgery. And the highlight of his academics has been that he has been the section editor for a very wonderful atlas of hand surgery by Professor Dr. Hardikar sir. Please purchase that book. It's a pictorial atlas on common procedures in hand surgery, in orthopedic surgery, in a step-by-step manner. So without further ado, I will like to invite our first speaker today, Dr. Anup Bansode, to speak to us on basic considerations in hand surgery, and his charge will be to speak on uh, distal radius fracture. Over to you, Anup. Thank you. I'm sorry, just before you start, Anup, I would also like to acknowledge Dr. Yogesh Khandalkar, who is serving as our moderator today. And I request all the speakers to please try and stick to the time. Basic etiquette will be to keep your microphones on mute. And Dr. Yogesh Khandalkar will be moderating this in terms of timekeeping as well as comments and questions that will be directed to the speakers. And he has been very instrumental in forming the POS PG group. And he is a very, very active and a very enthusiastic member of our executive committee. Thank you, Yogesh, for your contribution and your help at all times. You call him up at midnight, and he is there to help you out with anything that might be required. So without further ado, I request Dr. Anup Banswari to please start his talk. Thank you very much. Anup, could you please put your slides on full screen on a presentation mode and unmute yourself, please?
Hello.
Yes, Anup, we can hear you. Dr. Yogesh, please take over.
Yeah, Anup sir, please start your presentation. We'll be happy to hear you on the basic consideration of distal and radius fracture. Please elaborate everyone with the treatment part and other things which are done in your presentation. Thank you. Please go ahead.
Thank you. Thank you, Pune Orthopaedic Society, for giving me the opportunity to present. So I have been given a topic of basic consideration in distal radius fracture. So my scope of talk would be to understand the fracture pattern, identify those that require the fixation and instability patterns, understand the classification system and its application, approach and so forth, so on. Distal radius fracture is the most commonly seen in emergency room. It is about 3% of the all upper extremity injuries. It has a bimodal distribution, most commonly seen in younger age group ranging from 5 to 24 years. And these are usually high energy athletic injuries. And second peak would be in elderly, that is in predominantly in females. These are fragility and osteoporotic fracture. And attention should be given to these osteoporotic fracture uh, for the prevention of such fractures. The surgeon who is dealing with distal radius fracture should be well versed with the soft tissue envelope around the wrist joint and the ligamentous attachment around the wrist joint. So this schematic diagram shows dorsal and the volar extrinsic ligament of the wrist joint. The second image which you see is the arthroscopic view, from where you can see that the radioscapulunate ligament, long radiolunate ligament, and radioscapocapitate ligament, and ulnotripedal ulnolunate ligament, which are part of TFCC. And this schematic diagram shows bony landmarks of the distal radius. First diagram shows a dorsal aspects with the Lister's tubercle and the dorsal lip of the distal radius. And the second one is from volar side with scaphoid and the lunate fossa. I want to uh, I want to focus your attention towards the last image, which shows the lunate fossa and the teardrop, which is represented on the lateral view of the X-ray. The volar lip of the lunate fossa projects palmarward, 3 to 4 mm palmarward, as compared to the volar surface of the diaphysis of the radius. This is a very important landmark when you are assessing distal radius fracture. The standard radiographs are sufficient to evaluate the pathoanatomy of the distal radius fractures, but sometimes you need to take a traction views and CT scan to understand the uh, fracture uh, fracture anatomy and number of fragments and its location. So when you are evaluating distal radius fracture, you should know some relationship and some lines pertaining to the distal radius fracture. This is the normal X-ray PA view, which shows a normal radial inclination or a slope, which is averaging 23 degree, and palmar tilt of averaging 11 degree. This lateral view is a facet lateral view, which is taken in the plane of the lunate fossa. And the perhaps the most important bony landmark that you see in the lateral X-ray is the teardrop, which is uh, uh, the line which is drawn tangentially along the subchondral border of the teardrop makes a subtend an angle of 70 degree with the longitudinal axis of the radius, which is a teardrop angle. In case of volar fracture dislocation, that angle has increased. So you need to restore that teardrop angle while fixing such a fractures. Another important parameter is anteroposterior distance, which is measured from the dorsal to volar lip of the lunate facet, which may be increased in dipunched or volar split fracture of the lunate fossa or impacted fractures. Another parameter is the articular depth. So normally it is 4.8, which is measured from the AP line and perpendicular line drawn from the AP line to the articular surface. So the depth increase in the depth as compared to the opposite side, 2 mm or more is a significant, which is mechanically represented as the increase in the contact, increase in the radiocarpal pressure and decrease contact area, which further lead to arthritic changes, and clinically as represents the decrease in flexion and extension range of motion. Whenever require, you need to take a traction X-ray. This is initial X-ray, PA view and the lateral view. After traction, you will get a clear picture of number of fragments, degree of articular involvement, different fracture fragments, and reducibility of the fracture at the initial assessment. So recognition of the unstable pattern of the unstable fracture patterns is utmost important. So according to AAOS guideline, anything that is intra-articular displacement more than 2 mm, post reduction radial shortening of more than 3 mm, and dorsal tilt of more than 10 mm, these are the candidates for surgical interventions. And this is the landmark paper by LaFontaine and colleagues, which included some instability parameters.
Anup, I'm sorry, please unmute yourself. There was an error in muting. Please unmute yourself.
There was a landmark paper by LaFontaine and colleagues, which involved the instability parameter, that is dorsal comminution, dorsal angulation, ulnar fracture, shortening of more than 5 mm, and severe osteoporosis. So if there is 3 or more
Anup, you're on mute again. Please unmute yourself.
yes.
Yeah.
And this is the CT scan, which shows intra-articular fracture with articular depression. So from where this 2 mm figure have come, it is not an arbitrary figure. It has come from the landmark paper from Nurk and Jupiter, which shows that the 91% of those with residual articular displacement are associated with arthritis. There are various classifications to understand the fracture anatomy. Gartland, Frickman, Fernandez, AO, Mellon, and Collin concept. So intra-observer and intra-observer reliability increase with the CT with the use of CT scan. And I would like to show you this X-ray. You need to assess all the fragment in all views. There is PA view and oblique and lateral view. You need to check all fragment in each views. Recchi and Regazzoni developed the conceptual framework of columnar concept of distal wrist. These are the columns of the wrist: radial column, intermediate column, and the ulnar column, and further subdivided into fragment specific classification, which shows a dorsal wall fracture, volar ulnar, intra-articular step, and volar lip and radial styloid fracture. Intermediate column is the main load-bearing column. Idea is to stabilize all the columns and the components, starting with starts with a simple technique and then move on to advanced technique to address all the fragments. This schematic diagram shows fixation of the volar arenal fragment with a small T plate, and the second one shows the additional S plate for the styloid fracture. These small styloid and volar corner fractures are fixed with a buttress mode. These are some of the examples which are treated conservatively, and after 5 weeks there was a collapse. As you can see that there is a large styloid fragment, and in the lateral view you can see a small teardrop fragment which was missed on the initial X-ray evaluation. This is also one example, which is a dorsal fracture dislocation with an intra-articular step and dorsal rim fracture. So we went on to fix the main metaphyseal fracture with a teardrop with a volar plate. Then we add a styloid plate, and the volar dorsal ulnar corner fragment is addressed with a separate small plate from the dorsal aspect. This is also one example of dorsal ulnar corner fracture. Which was also fixed from volar and dorsal aspect. So we usually use a standard volar approach. On the incision is taken on the FCR. FCR is retracted, and FCR is retracted radially, and that's when you see this FCR subsheet which was incised, and the median nerve and the FPLs are retracted medially. Pronator quadratus is elevated from the radial border and the distal border like a L-shaped flap in order to cover the plate later on.
Sorry to interrupt. The video is not playing. Can you please play the video?
The video play होत नहीं. Video is not playing. So I'll move on to next slide. Sometime when there is a comminuted fracture with radial styloid fracture, so you need to release the brachioradialis in order to get the radial styloid reduction. Variable angle plates are useful in holding different fragments of the comminuted distal radius fractures. These are divergent screws. So volar plate gives anatomical restoration, secures articular congruency, increased rigidity, and allows early motion. So advantage of volar plate is there is potential space for the plate to place over the volar aspect, which can be covered by pronator quadratus after fixation. The main anatomical consideration is that there is a watershed line beyond which you can't place your plate, because there is a chances of flexor tendon attritional rupture and post-operative stiffness.
Anup, we can't hear you.
Go ahead, speak.
Yeah. So this diagram shows whenever there is a distal radius fracture, there is a coronal translation of distal fragment leading to lax intraosseous membrane. So which causes distal radioulnar joint instability. So you need to radialize the proximal fragment in order to get intraosseous membrane taut and thereby stabilizing the distal radioulnar joint. So disadvantage of volar plating is hardware, intra-articular hardware, attritional rupture of the tendon, malurinary infection. So problem arises when there is oversimplification of the distal radius fracture. So this fracture is not equivalent to the this fracture because there is a styloid fracture, lunate fossa fracture also. So volar locking plates are tremendously popular, but one plate does not address all the fracture fragments, and plate does not reduce the fracture. These are some of the examples where marginal volar fragment was missed at the initial fixation. You can see that the lunate fossa fragment was missed at the initial fixation, leading to volar subluxation and dislocation of the wrist. This is another example. This is volar fracture dislocation with volar lip and intra-articular fracture, which was addressed by a rim plate, which almost go up to the volar lip of the distal radius. So you need to
Anup, we can't hear you.
so you need to restore the radiocarpal axis while doing the fixation. Sometimes there is a dorsal ulnar fracture or dorsal rim fracture which requires a dorsal approach. And indication is multi-fragmented dorsal displaced fracture of the distal radius and dorsal bony defect due to high velocity injuries. In such a cases, you should wait for 5 to 7 days to edema to reduce and for better visualization of the fracture fragment and stabilization. So you take a midline incision over the Lister's tubercle and identify the EPL and exteriorize is outside the compartment and evacuate the hematoma. Go between third and fourth compartment, elevate sharply and reduce the fracture fragment and fix it. If required, bone graft can be punched subchondrally. If there is a die punch fracture, arthroscopically assisted intra-articular fracture reduction is useful, where you can do a dry scopy and elevate the subchondral fracture with a punch and add a bone graft and fix it with a plate or a cable. So distal radius fracture will continue to challenge us. Understanding of our failure of fixation can improve our future success. Careful assessment of the fractures can determine what the optimal fixation should be. Each fracture is unique. You should treat it as a different fracture, and it is the surgeon and his or her understanding of the fracture, not the hardware. Thank you.
Yogesh sir, can you please?
Yes, Anup, it was a very good presentation. You have elaborated us with the various angles, basically what has to be seen anatomically, along with the teardrop and other things. It was a
Yes,
very
sir.
good presentation, and it shows us how to select a plate, type of plate, and type of fixation. You correctly elaborated on the about the dorsal part. Sometimes the people are confused with the dorsal approach or volar approach. So maximum done is
Yes,
a volar approach nowadays, but there are specific indications for the dorsal fixation and fractures, which are given some points and elaboration to us. That was a nice presentation. I hand over the mic to again Vaigavkar sir for next presentation. Thank you.
Thank you, Anup. That was a good talk. And distal radius fractures, they keep on challenging us, and understanding the basic tenets of this injury in terms of how to diagnose, what are the radiological nuances, what are the implant considerations, what are the surgical or the approach considerations, and uh, recognizing that one single plate may not be enough in a large majority of people is something which is very important takeaway on this particular talk. Thank you, Anup. I
thank you.
call on our next speaker, Dr. Shailesh Patil, to please speak on considerations in wrist fractures. Dr. Shailesh, thank you. Shailesh, we can't hear you. Can you please unmute yourself?
Yeah.
Yeah, now we can hear you. You're muted again.
Yes.
Yeah.
Good afternoon, sir. Thank you, POS Secretary, Dr. Karne sir, President, Dr. Karne sir. Thank you, Dr. Abhijit Vaigavkar, POS Secretary, all the esteemed POS members, for giving me opportunity to talk on the basic consideration in carpal fractures. Before going for a carpal fractures, I would like to see some anatomy, blood supply, and the various angles. We'll go through some brief anatomy. There are 8 carpal bones, proximal row, there are 4, and distal row 4. We can start from scaphoid, lunate, triquetral, pisiform, hamate, capitate, trapezium, and trapezoid. So it's a very common mnemonic that everybody knows, that still looks too pretty, try to catch her. The scaphoid is a boat shaped, whereas the lunate is a crescent shape, and triquetrum has a 3 sides. The pisiform is like a P shape. So distal row contains the trapezium, trapezoid, capitate, hamate. The trapezium is irregular, and the trapezoid is four-sided. Capitate has a head, which is the keystone of all the carpal bone, and the hamate, which has a hook. So first we'll start with the scaphoid, because scaphoid fractures are very common in all the carpal fractures. So it accounts near about 50 to 60% of carpal fractures. So the interesting part is the scaphoid is completely articular portion. It has articulation with the radius, trapezium, trapezoid, lunate, and capitate. The proximal surface with a radius, the distal surface laterally with the trapezium and trapezium, medial, and capitate. And the ulnar surface, the lunate is articulated. So near about 80 to 90% articular area is completely articulate with the other carpal bones. So ligaments wrist, as Dr. Anup has explained about the various ligaments on the wrist joint, but these ligaments are very important to understand the directions, where they are coming, where they are going. So the palmar radiocarpal ligament, there is a radioscaphocapitate ligament. This is the important ligament which arc over the radius and the ulna. The long radiolunate ligament, this you can see the long radiolunate starting from the radius and goes to the ulna. And the radioscaphal ligament, this is radioscaphocapitate and short radiolunate ligaments. The palmar and ulnocarpal ligaments, these are important ligaments, as well as the palmar midcarpal ligament arising from the scaphoid, trapezium, scaphoid, capitate, triquetrocapitate, triquetrohamate. And the dorsal ligaments, the dorsal ligament, the dorsal radiocarpal ligament, dorsal intercarpal ligament, and also scaphotriquetal ligament. This helps to bind the carpus with each other. So the anatomy of these ligaments is very important, so that if someone insufficiency is there of that ligament, if there is a rupture, the chances of complete instability around the wrist will be there. So the proximal row, the interosseous ligament, these are the ligaments present within the joint, that is scapholunate interosseous ligament and lunotriquetral interosseous ligament. This dorsal row interosseous ligament, the trapezium, trapezocapitate, and capitohamate ligaments. The vascular anatomy is very important because all the fracture of the scaphoid depends on the how it is healing, whether there is a complete healing, long union, delayed union, depending on the portion. The anatomy of the scaphoid is important. The retrograde blood supply mainly from the radial artery, the polarly from the superficial palmar branch of the radial artery, and dorsal from the dorsal carpal branch of the radial artery. So the distal portion is mainly supplied by the vessels, whereas the proximal portion is less supplied. So the proximal pole AVN, that is avascular necrosis, there are high chances, near about 30 to 15% chances of AVN. So as we have seen the vascular anatomy, you can see the graph. If the fracture is in the proximal distal pole or waist, the union rate goes down as we go from the distal to the proximal side. So the anatomical location of the fracture will guide us whether this fracture is going for AVN or delayed union or not. We'll just go focus for the biomechanics of scaphoid fracture, that is scapholunate angle, the angle created by the longitudinal axis of the scaphoid. This is the longitudinal axis of the scaphoid, and the long axis of the scaphoid is a line tangential to the palmar convex surface. This is the long axis of the scaphoid, and this is the line perpendicular to the long axis of the lunate. This is long axis of lunate will intersect here, which gives rise to a 30 to 60 degree, that is a normal scapholunate angle. You can see here. The next angle is a scapholunate angle, capitolunate angle, and interscaphoid angle. So these angles are very important, whether we can see whether it is in VC or DC deformity afterwards. The normal scapholunate angle is 45 to 60 degree. It is greater than 60 degree, means there is abnormal angle. You can see the capitolunate angle. This is a capitate and this is the lunate. The angle in between is normally 10 to 15 degree. If it is more than 10 to 15 degree, then definitely there is an abnormal capitolunate angle. And this is a schematic representation of radiolunate angle. Here we can see this is a scaphoid, long axis of scaphoid. This is a long axis of a lunate, and this scapholunate angle is very important. It is 45 degree normally, but in DC means dorsal intercalated segmental instability. There is a dorsiflexion of carpal instability, and the dorsal tilt of lunate is there. You can see this lunate is dorsally tilted, and polar tilt of a scaphoid is there. So scapholunate angle is more than a 60 degree. in DC. Whereas in VC, the scapholunate angle is less than 30 degree because volar tilt of lunate is there. Lunate is tilted volarly and capitated is tilted dorsally. So it helps this, if you know this biomechanics, then you can see whether the instability is there in the wrist or not. This is SNAC, there is scaphoid non-in and advanced collapse. There are 4 stages depending on the arthritis of the radial styloid or scaphoid fossa or capitulunate fossa or the diffuse arthritis of the all of the carpus. Basically, the clinical presentation of scaphoid fractures, there is a history of trauma. It is not 50 to 60% fractures occur in the low energy trauma, means contact sports or fall from the wrist, the fall on outstretched hand. There is 5 to 6% high energy trauma, the fall from height or anything that causes scaphoid fracture. The presentation is like swelling, pain, decreased range of movement. The terminal flexion or extension of the wrist is also decreased. Anatomical snub box tenderness is present in the waist fracture, nearly about 70% of the waist fracture. You can palpate the anatomical snub box while doing the waist examination. Distal pole and the scaphoid tubercle on a palmar aspect, and proximal pole in line with the secondary distal to the dorsal radius layer. You can go for a scaphoid compression test. I'll just tell her that where you can palpate the snub box tenderness. Here is the snub box. We can palpate the waist fracture here. If it is this proximal pole, we can just palpate the tubercle here. That is scaphoid tubercle. We'll see the tenderness at this point. Or you can dorsal. You can palpate this. This is Lister tubercle. You just go below the Lister tubercle. There is a sulcus. There is a radiocarpal joint. And the prominence is the scapholunate joint. You can move radially from this joint. You can feel the proximal. So this anatomy you should understand so that you can clinically palpate whether the fracture is in the waist, fracture is within the proximal pole or distal pole or in the tubercle. You can do the scaphoid compression test. That is, the axial load is given from the metacarpal, the thumb, directly on the scaphoid. The grinding will cause pain. This is very important. The next is how to position during X-ray. Usually, the shoulder, elbow, wrist should be at the same level. This elbow, wrist, and the shoulder, it should be at the same level. And the wrist is at the ulnar division. So this position will clearly see the PA view of the wrist joint. The scaphoid series, it contains the PA view, dead PA view, dead lateral, PA ulnar deviation, 45 degree supinated, 45 degree pronated oblique view, which will give the complete length of the scaphoid because it's a boat shaped. So you can see in all the images, not a single image can catch the scaphoid fracture. We have to go for the multiple views so that we can see the complete scaphoid in a X-ray imaging. Next is a CT scan. It's very usual that sometimes the X-ray you can't see anything on day one. Then we just put a below elbow cast thumb spica and send the patient home, and we can call him after say the 10 days, and we can go for ideally we can go for MRI because MRI will pick up the occult fracture. I will come through the MRI only, but before that we'll just see the CT scan. The CT scan, the long axis of scaphoid, we should take it in. Patient should lie prone with the arm overhead, Superman position. The sagittal plane forearm is pronated, and the coronal plane forearm in neutral position. Ideally, you should take 0.6 mm cut or 1 mm cut so that we can see the complete scaphoid within the CT scan images. If it is bigger than 1 mm, it's very difficult to notice the small fractures within the CT scan. But CT will definitely help in non-union as well as in the delayed union cases. This MRI is very sensitive, that is 90 to 100% sensitive, but the specificity is near about 90%. It can determine occult fracture within 24 hours also. The vascularity of fracture you can see the vascularity fracture in the non-union or avian. You can go for a contrast MRI also, or you can go for say bone scan, but it is not feasible, it is not affordable. So better way is go for a scaphoid series X-ray, and if it is not showing anything, then you can go for an MRI or a CT. Sometimes you can do the MRI and limited cut CT so that you can see both the things on a MRI as well as a CT scan. That will be the best practice if it is not seen on within first week. I just will like to go for a fracture classification. This is the type A, type B, type C fracture. You can see the type A, A1 is a fracture of tubercle, the incomplete fracture. These are the stable fractures. The unstable type B is unstable acute fractures. There's a B1, B2, B3, and B4. The distal oblique fracture, the complete fracture of the waist, proximal pole, transcaphoid perilunate fracture dislocation. Type C is the delayed union. Type D is fibrous union or pseudoarthrosis. And the Mayow's classification, depending on the location, whether it is in a distal tubercle, or distal articular surface, or distal third, or middle third, or a proximal third. And depending on the fracture pattern, that is horizontal oblique, transverse oblique, or vertical oblique, transverse or vertical oblique. Vertical oblique is more unstable than the transverse or horizontal fracture. The management of scaphoid fracture, the 25% of fracture not visible on the X-ray. If doubt, give thumb spica cast, follow up after 10-14 days, repeat the X-ray. Negative follow-up X-ray, then go for MRI. It will help in the diagnosis of the scaphoid fracture. This is a treatment algorithm. That is, if stable fracture, tubercle fracture is there, then you can go for a short-term cast for 6 to 8 weeks. If distal third fractures, incomplete fracture, you can go for a short-term cast. The unstable fractures, so the waist fractures, you can go into mini open or percutaneous, particularly percutaneous fixation if it is undisplaced. The proximal flow fractures, you can go for a percutaneous fixation. It may be a dorsal approach. A displacement, if it is unstable, means what? The displacement is more than 1 mm, lateral interscaphoid angle of more than 35 degrees, and there is bone loss or comminution, perilunate fracture dislocation or DC deformity is there, then these are the unstable fractures. Then we have to go for a open reduction or mini open fixation, either with a dorsal approach or ulnar approach. This is a surgical treatment. You can see the percutaneous scaphoid fixations. We can make the marking in AP and lateral and just take an entry point, divide the distal pole in a 3 quadrant. In the outer third quadrant from the radial side, you can put the wire. Sometimes we have to nibble out the trapezium. So you can see the placement of guide wire, and over the guide wire, you can drill. These are some cases. You can see the proximal pole, distal pole fracture here, and the fixation with a Herbert screw. The pitfalls is place guide wire centrally in a scaphoid. The very important thing is guide wire placement. If your guide wire is in a central position, then the half of the surgery is done. Use derotation wire. You can put another wire so that there is no movement while drilling the uh, guide wire over the wire. Avoid using long screw. You should subtract minimum 4 mm from the measured distance. Common screw length is minimum 20 mm. Don't trim past the far cortex. If resistance is there while trimming, stop and look whether the wire is bent or broken. There are high chances because the size of wire is very thin. These are the volar approaches. You can see the scaphoid tubercle and the FCR tendon. You can expose. This is for the volar approach is best for the scaphoid fractures and distal to the best, comminuted fractures, or sometimes with bone grafting in non-union scaphoid, we can go for a volar approach. Dorsal approach, the proximal flow fractures or the excision proximal fragment of non-union scaphoid or scapholinate ligament rupture. it is better to go for the dorsal approach. Make a straight dorsal incision starting with the listed supercle and extending for about 4 centimeters distally. Carefully preserve the dorsal superficial branch of the radial nerve. That is very important, which runs in the radial skin flap of the wound. Incise the EPL, retiniculum or the EPL, and open distal part of the third extensor compartment. And capsular repair is very important afterwards. But the complications is delayed union, non-union, arthritis, reduced wrist range of movements, loss of strength, muscle atrophy, disease osteopenia, CRPS, wrist instability, because sometimes there is a tear of SL ligament which is not addressed at the time of surgery. AVN, which is also a dreaded complication of scaphoid fracture because of the anatomical fracture site. The next variety is a transscaphoid perilunate fracture dislocation. The uncommon injury, many of the times, it's nearly 25 missed in 25% of cases on initial presentation. The 5% of wrist fractures account for the transscaphoid perilunate fracture dislocations. It is usually associated with a high energy trauma, a fall from height. The mechanism of injury is forceful wrist extension, ulnar deviation, and intercarpal supination. Before going to the transscaphoid perilunate dislocation, we have to Gilliland's arcs. We have to know the Gilliland's arcs. What is the first arc? There is a smooth curve outlining for convexity of scaphoid, lunate, and trachea. And the second arc distal to the concave surface of the scaphoid, lunate, and trachea. And third arc is the proximal curvature. This is the proximal curvature of the capitate and hamate. So this Gullila's arch should be restored while doing the surgery. Second is a greater and lesser arc injuries. The greater arc injury is associated, these are the greater arc injuries, this is associated with the fracture of scaphoid, capitate, the radial styloid as well as the ulnar styloid also. So the force, it gives us direction where from the force is traversing from one point to the other point. The lesser arc injury is usually the ligament injury. As I discussed, in greater arc injury, it takes transosseous route through the scaphoid disruption and unitracheal interosseous ligament and fracture ulnar styloid. The proximal fragment of scaphoid lunate remain with a radius, while distal scaphoid fragment dislocate dorsally to lunate with attached distal carpal. There are different variations along with the fracture capitate or fracture of the triquetrum or fracture of the radial styloid or ulnar styloid. You can see. This is the normal lateral view. You can see the capitate, lunate, and radius. In lunate dislocation, lunate is out of the row. And in perilunate dislocation, the distal, the capitate, along with all the carpus goes dorsally. So this is a basic lunate dislocation and perilunate dislocation. These are some cases where you can see the on APV you can see there is a loss of Gulliland's arc. You can't make it properly, and lateral X-ray the lunate is out. You can see here. So treatment will be the open reduction with internal fixation with a dorsal approach for scaphoid fixation and scapholunate tear. The extended carpal tunnel approach, sometimes because of lunate dislocate polarly, there is pressure on the median nerve, which gives the initial signs symptoms of carpal tunnel. So we have to extend the incision proximally and release the median nerve so that the pressure on the median nerve is completely restored. You have to restore the Gulliland's arc, ligament repair, the K wire for lunotriquetral ligament injury or bury. You have to bury the K wires because we have to keep it for minimum 10 to 12 weeks. Or you can, if the ligaments are enough, then you can use the suture anchor. These are the some cases. You can see the fixation of the intercarpal are done with a K wire. This was an interesting case. The history of fall from minimum 12 to 15 feet height In general surgeon has taken is for laparotomy and they said that something is wrong in the wrist. Just I went there and saw that is complete dislocation, the fracture dislocation of scaphoid. Scaphoid, you can see scaphoid is completely in a forearm completely, along with the disruption of distal radius, along with the ligament. You're fixed with, and the rest of the corpus, as we have seen, the scaphoid, scapular dislocations, then we'll go for a triquetral fracture. And 15% of all corporal fractures account for the triquetral fracture. There are different classification depending on dorsal, triquetral body fracture or palmar cortical fracture. Triquetral, there's a small fragment, no instability, then go for a cast for minimum 4 weeks. If it is small fragment, then you can excise. If it is body fracture, then you can ORF with a screw with displaced body fracture. Every time you have to see that there is any associated ligament injury along with any fracture. You can see there is small flake here, the triquetral. That can be a concern. Next, we'll go for the trapezial fracture. There's a Walker classification. There's a type 1 horizontal fracture, type 2A radial tuberosity through CMC joint. In type 2B, radial tuberosity through scaphotrapezium. In type 3, the ulnar tuberosity. Type 4 is the CMC joint, and type 4 is a comminuted, seen in the high velocity trauma, and associated with the Bennett's fracture also. Imaging the back view, you have to see the complete dead lateral view of the thumb, the carpal tunnel view. See the
Shailesh,
volar.
sir, sorry to
Yes, sir.
interrupt you.
Yes,
Shailesh,
sir.
sir,
Yes, sir.
can we little bit go
Yes,
ahead?
sir. Yes, sir.
So,
Yes.
I think
Only 1
time-
minute. 1
yeah,
minute.
that's
Donated AP view, CT scan, you can see non-displaced short-term cast, and in displaced, we can go for a ORF. The hamate fracture, we'll just run out. The type A is through the hook of hamate, the tip, west, at the base of the hamate. And then type 2 body fracture, the proximal or medial tuberosity or dorsal columnar fracture. This is the hamate fracture. You can see on the CT, the best view seen in the carpal tunnel view on X-ray, or you can go for the CT. CT will give us there's a fixation of hamate, the percutaneous fixation of hook of hamate. Thank you. Thank you. Thank you for patience listening.
Yeah, thank you, Shailesh, sir. It was a very elaborate and good presentation with a lot of analytical stuffs, and you mentioned the very aptly the correct entry point for the scaphoid, that is lateral 1/3, where people miss it, and center of the scaphoid, then gilula lines, and at the end you mentioned about the various carpal injuries. They're very elaborative and very informative. That has been helping us a lot, along with all general orthopedic surgeons. So it was a very nice presentation. Thank you. I hand over mic to Vaigaukar, sir.
Thank you, Dr. Shailesh. It was a very lucid talk. We understand that carpal injuries is such a vast topic that it is impossible to do justice in such a short time to so many bones. There are 8 bones and they have so many different nuances to it. But suffice it to say that of these 8 carpal bones, the commonest fractures that we'll see in clinical practice are those obviously of the scaphoid, and then we do see these fracture dislocation patterns. You know, you have a fracture of 1 or 2 carpal bones, and then there is an instability or a dislocation pattern. And recognizing these injuries and then treating them appropriately, if one is trained and adept at dealing with these injuries, they can do it, or maybe they could collaborate with an expert to deal with these injuries in a more appropriate manner. The biggest problem is missing these injuries. Dr. Yogesh, I would like to ask you as to, in your clinical practice, ever since you started your practice, how
Yes,
many
sir.
have you seen of such injuries and how many have you missed?
Luckily, sir, I was very lucky to have all the injuries which are not missed. But lucky, I didn't get the. He has shown the best case. The lunate is totally displaced, and the general surgeon was very apt to call him. The maximum times I've seen were the referred patients where people have missed the palpation, as Dr. Shailesh has correctly mentioned. about the proximal pole palpation, then waist palpation, and the scaphoid fossa palpation. These are very different things, and he has nicely mentioned about the test also, compression test of the scaphoid. So many times I have seen jugular lines and arcs are missed by other people, which have picked up, and I have tried to treat it very nicely after doing the proper CT and MRI also. As you correctly mentioned about the CT, that 0.6 mm cut is very important, rather than it's a 1 mm cut, which shows the good thing, and that has to be taken into our practice so that we can have good treatment to the patients and we can have good outcome also.
Right.
Thank you.
Because the hallmark of especially the perilunate injuries, including just the dislocations or the fracture dislocations, is that these are the commonest missed injuries. Especially a word to our young orthopedic surgeon colleagues that please look at the Gilula's line, please take proper x-rays, and more often than not, the x-rays themselves are enough to help you with the diagnosis. And then if you're still not very sure, a CT scan, getting traction views should help quite a bit. And the second most commonly missed injury, obviously, is scaphoid fractures. A lot of times people come to you with a history of fall, and then the initial x-rays may not reveal a fracture. But if you have tenderness in the anatomical snuff box on the dorsal aspect over the scaphoid and on the volar aspect over the tubercle, you should assume that there is a fracture, treat it as such, repeat the x-rays at 2 weeks. If you still do not see a fracture and the patient still has tenderness, get an MRI done, and that would more often than not, reveal the X-ray. Dr. Shailesh, very quick question to you before we move on to the next talk. What are your indications for an MRI and or a CT scan in scaphoid fractures?
In an acute injury or in a chronic?
In general. So tell me what the indications are for an MRI. When is it that you would get an MRI done? When is it that you would get a CT scan done?
If the initial injury is there and you cannot see on the follow-up X-ray also there is no fracture, then it's better to go for an MRI, because MRI will pick up the occult tissue.
Great. And for a
Go
CT
for
scan?
a CT. Hello?
Yeah, what is the indication for a CT scan?
Am I audible, sir?
Yeah, you are audible. Can you hear me?
Yeah.
So
If there is associated fractures along with, if there is any high velocity trauma and there is associated fractures, then better to go for a CT. So it will show the other fractures also.
Okay.
So if it is low energy trauma is there, then go for MRI. If it is high energy trauma, then go for a CT scan.
Okay, great. So, and I think also CT scan would be more beneficial in late presentations or to assess the healing after surgery.
Yes.
Or non-unions, established non-unions for that matter. And again, an MRI in a late case would be a proximal pole fracture where you would want to look at the avascular necrosis. However, one caveat is that an MRI is not the most accurate assessment of AV and proximal pole fractures. And visualizing the fragment and looking for punctate bleeding would be the most accurate assessment. Would you agree on that, Dr. Shailesh?
Yes, sir.
Thank you so much. And we'll move on to the next talk. I'll request Dr. Satish Mane to please talk to us on fractures of the hand. And again, this webinar was designed to stress more on the basics, the basic considerations. And hand fractures, again, metacarpal and phalangeal fractures are so common in clinical practice. So let us try and understand what the basic tenets of diagnosis and treating hand fractures are from Dr. Satish Mane. Dr. Satish, thank you very much. Over to you.
Hello. 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 Am I audible?
Yes, Satish, you are audible.
Yeah, thank you. Good afternoon, everyone, and I would like to thank Pune Orthopedic Society for giving me this opportunity to talk on the hand fractures basic consideration. I will briefly describe the common hand fractures and the treatment options available, as it is a very vast topic and cannot be included in a single talk. So I will try to describe it briefly. Metacarpal and phalangeal fractures are the very common injuries of upper extremity. Most of them can be managed non-operatively, but few fractures require the operative fixation. Over last decade, there is increased trend of operative fixation for hand fractures because there is a improved material, implant designs, and the instrumentation. Also, there is a better understanding of the biomechanical principles of the internal fixation. The pre-op and the intraoperative radiographic imaging is also improved, and not to forget, the post-operative therapy and rehabilitation program is greatly improved. Uh, the common indications for operative fixation are irreducible and unstable fractures, the fractures associated with deformities like malrotation, shortening, the articular fractures, the fractures associated with the segmental bone loss, and associated with the soft tissue injuries. These are the common indications to consider for the operative fixation. Uh, to determine the optimal treatment for hand fractures, one should look for the fracture location, whether it is articular or extra-articular, the geometry of the fracture, whether transverse, spiral, or comminuted. Associated deformity and soft tissue injuries also plays a role in determining the operative treatment. One should also consider the patient's age, his occupation, socioeconomic status, and associated systemic illness while uh, advising the operative treatment. The metacarpal and phalangeal fractures are commonly classified for the ease of practical purpose into the depending on the location into head, neck, shaft, and the base fractures, which can be further subclassified into the depending on geometry into the transverse fractures, spiral, oblique, or the comminuted fractures. So, starting with the metacarpal head fractures, these can be the intra or extra-articular fractures, epiphyseal fractures, ligamentous avulsions, or the comminuted fractures. In addition to the routine PA lateral and oblique views, Brewerton view plays an important role in assessing the metacarpal head fractures. It is taken with fingers flat on the X-ray film with the MP joint flexed to 65° and X-ray beam angled from ulnar to radial direction in 15 degrees. The metacarpal head fractures, which are undisplaced and stable, can be immobilized in a plaster cast with MCP at 60 to 70° flexion. The non-comminuted and displaced fractures, which constitute more than 25% of the articular surface or articular staph of more than 1 millimeter, operative treatment is usually needed. That can be performed using the K-wires, headless screws for non-communicated and the displaced fractures. If the head fracture is very communicated, the multiple K-wires and even the external fixator with MP in slight flexion can be considered. Coming to the metacarpal neck fractures are more common in the border disease, that is the fourth and fifth metacarpal. They are often called as a boxer's fracture, but it is a misnomer because it is rarely seen in professional boxers. In fact, it is more common in brawlers and the people who hit the solid objects with clenched fist, which makes which objects and angulates the fracture with apex dorsal. The fracture usually angulates dorsally because the impact occurs over a dorsum of the metacarpal head that causes the comminution of olar neck, metacarpal neck. And also the intrinsic muscles that crosses the MP joint, they lie olar to the axis of rotation and keep the metacarpal head in flexion. So it is very important because the to reduce the metacarpal neck fractures. The treatment again depends on following factors such as the which metacarpal neck is fractured, degree, what is the degree of angulation, there is a whether there is a rotational deformity or pseudocloying present. Pseudocloying is nothing but the because of excessive fracture angulation, the MP joint goes into the hyperextension and PIP goes into the flexion. The most metacarpal neck fractures, as I earlier said, they occur in ring and the small fingers. For ring finger, 30 to 40-degree angulation is acceptable, and for small finger, 50 to 60-degree angulation is acceptable because they provide the 20 to 30-degree movement in the sagittal plane. But for the index and the middle finger, angulation greater than 10 to 15 degrees is not acceptable because lack of the compensatory CMC motion. To reduce the metacarpal neck fracture, JAS maneuver is used, which is performed by applying the olarly directed force to the proximal metacarpal and dorsally directed force to the distal fractured fragment, which is exerted by pushing the proximal phalanx against the metacarpal head, and it will help in the reduction. After reduction, if the fracture is stable, you can immobilize in the cast or can be fixed with the K-wire. There are various methods of K-wire fixation like antegrade, we also call it as a bouquet technique. One can fix the retrograde intramedullary or cross K-wires, or even one can fix the fracture with transverse K-wires passing to the adjacent metacarpal. While fixing the fracture, metacarpal or phalanx, one should always look for the rotational deformity because the rotational deformity is not accepted at all before reduction and after reduction also, and it is one of the common indication for the operative treatment. So the metacarpal shaft fractures can be, as I said earlier, they can be classified into the transverse, spiral, oblique, or the comminuted fractures. They can be fixed with varied modalities like K-wire fixation, IFS screws, plating, and all other modalities. K-wire fixation can be done by antegrade or retrograde, cross pinning, transverse, and the transverse pinning. Here is one example of the fifth metacarpal shaft fracture, which is treated by the retrograde intramedullary K-wire, and you can see the reduction and the angulation is corrected. The similar implants or K-wire can be used for the phalangeal shaft fractures of similar nature. Then again, the intramedullary screws or the intramedullary we call as a nail are also available for the metacarpal shaft, neck, or the base fractures. But unfortunately, they are not available in India right now. The spiral or the long oblique fractures usually best treated by the interfragmentary screws, either by the close reduction or by the open reduction. Uh, some fractures require the open reduction, which are unstable and irreducible by the close method. We usually prefer the dorsal approach and extensor tendon splitting, and then can be fixed depending on the fracture geometry by the IFS interfragmentary screws or by the plating or even by the K-wires. The metacarpal base fractures are again common in the first metacarpal and the fifth metacarpal. Thumb metacarpal fracture, base fractures are classified usually the extraarticular and the intraarticular. Extraarticular fractures again can be short transverse or the short oblique. The intraarticular fractures are we usually describe as a Bennett's fracture, Rolander's fracture, and comminuted fracture. The first metacarpal extraarticular fractures are usually occur at the junction of metadiaphyseal and referred as epibasal fractures. A true lateral radiograph is almost necessary to confirm or to determine the degree of angulation. To reduce the extraarticular fractures, we have to give the longitudinal traction and downward pressure over the fracture, apex of the fracture, with mild pronation of the distal fragment, as distal fragment is usually goes into the adduction and flexion by the deforming forces of the adductor polysaceth and the APP muscle. Once the reduction is achieved and is stable, can be fixed, can be immobilized in cast or can be fixed with the K-wire. We usually prefer the K-wire because we find that these are unstable fractures later on. In the extraarticular fractures, angulation of less than 30 degrees is usually accepted because of the abundant motion at the CMC joint. But greater than 30 degrees will result in the compensatory hyperextension of the MP joint. Bennett's fracture is nothing but the articular fracture of first metacarpal base constituting single variable size volar ulnar fracture. The Ola GEDA again classified Bennett's fracture into three types. Type 1 is a large Bennett's fracture fragment with subluxation. Type 2 is the impacted fracture without subluxation. Type 3 is the small Bennett's fragment with subluxation or dislocation. To reduce the Bennett's fracture, first we should know the deforming forces over the fracture. The Bennett's fracture fragment is held in position by the olar oblique ligament, or we call it as a Palmer-Beck ligament, and the rest of the metacarpal pulled by the abductor pollicis longus dorsally, radially, and proximally. So for reduction, we have to give the longitudinal traction, pressure at the thumb metacarpal base, and the pronation of the distal fragment. And after reduction, it should be fixed with the K wire. Or if the fragment is large, one can use the screws also. Uh, Again, the pinning can be done in a various ways. One pin in the trapezium and other in the second metacarpal base, or both parallel, or both into the trapezium. Uh, Bennett's fracture, which are reducible and unstable, should be treated by the open reduction by the Wagner's approach. Once the reduction is achieved, they can be fixed with the plate, screws, or the K-wire. Rolander's fracture is nothing but the any comminuted articular fracture of the first metacarpal base. It can be classical Y or T shape, or can be comminuted. Uh, Rolander's fractures are treated. These are the rare injuries, but very difficult or challenging to treat, and almost always require the open reduction for the fixation. So once we open the fracture site, it can be fixed with the K wires if it is a classical three-part fracture, or can be used, can be treated with a plate. If the comminution is very severe and cannot be treated by the K-wire or plate, the thoraine traction or the oblique skeletal traction is one of the alternative to reduce the fracture. The K-wire is passed obliquely distal to the APL insertion and existing into the first wave space. Then the forearm cast is applied with a banjo outrigger, and the rubber traction is given to the K-wire. That will help the distraction and reduce position in place. It is usually kept for 4 to 6 weeks. Buckler again describe another method for such hugely comminuted fractures with quadrilateral mini external fixator associated with the limited open reduction and fixation with K-wire and in SOS bone grafting if needed. As I said earlier, Rolando fractures are very challenging, and these are outcomes are not good. The incidence of degenerative arthritis is usually related to the degree of comminution. The metacarpal base fracture dislocations are common on the terminal disease, that is the fifth metacarpal, which is the most commonly dislocated. Uh, it is usually an unstable fracture, and it needs fixation either by the close reduction or open reduction with K-wire or the screws. Here is one example, fifth metacarpal fracture dislocation, which is treated by the K-wire, which are removed after the 6 weeks. Coming to the distal phalangeal fractures, we start with the distal phalanx. Distal phalanx fractures are classified into the tuft fractures, shaft fractures, and the articular fractures. The tuft fractures are common injuries and secondary to the crush injury. They are often associated with the nail bed injury. Some closed tuft fractures are present with a painful subungual hematoma. Treatment is rarely needed for the fracture as per se, but the underlying nail bed repair and the wound management is the mainstay of treatment. For the closed subungual hematoma, trephination will help to reduce the pressure and relieve the pain. Epiphyseal injuries, we also call as the Seymour fractures of distal phalanx, are common injuries seen in the toddler. They can be treated with irrigation, debridement, fracture reduction, repair of the nail bed. The nail plate is usually replaced back underneath the proximal nail fold, which help to maintain the fracture in place or reduction in place. Then the mallet fracture or the mallet finger is nothing but the extensor tendon injury in zone 1. It can be either soft tissue injury or the associated with the bony avulsion. That is classified into the 4 stages. I will not go into the details. But for the soft tissue mallet, non-operative treatment usually suffice. We recommend 6 to 8 weeks splinting across the DIP joint in extension, and again night splinting for another 6 more weeks. The bony mallets can be treated with the operative method, with extension block pinning or pull-out technique or anchors. The extension block pinning we call as a Ishiguro technique is very commonly for pump over. First K wire is usually goes obliquely to the head of the middle phalanx, and the second K wire, after reducing the fracture, goes across the DIP joint line. The pull-out technique and anchors are the open reduction measures. I will not go into the details because they are out of the out of scope of this talk. The avulsion of FDP from the distal phalanx is called as a jersey finger, which is classified by the Lady and Packer into the 5 groups depending on the position of the FDP, where it lies, whether it lies in the palm, finger, and associated with the bony avulsion or not. The treatment options for the jersey finger, if the distal stump is intact and of good quality, we use the modified Kessler technique for the core suture and circumferential 60 running suture with the ethylene 60. If the distal stump is not available, then tendon to bone repair is advisable, and that can be done by the pull-out technique or using a 2.4 millimeter anchor. The post-op rehabilitation for jersey finger is very important. Wrist is kept in the flexion 20 to 30 degrees. MP joints are kept in flexion 60 to 70 degree. PIP and DIP joints are either neutral or slight flexion. At 3 weeks, we start the isolated range of motion exercises, and splint is discontinued usually at 6 to 8 weeks. Middle and the proximal phalanx fractures again classified into the articular and the non-articular. Articular fractures are condylar fractures, base fractures. They can be comminuted or fracture dislocation. Non-articular fractures, as I earlier said, for the metacarpal, they can be at neck, shaft, base, and transverse, oblique, and spine. Condylar fractures again subclassified, that is the London's classification, into the 3 subgroups. Type 1 is a stable fracture without displacement that can be managed conservatively with body taping. Type 2 is a unicondylar unstable fracture and always needs a fracture fixation. Type 3 is a bicondylar comminuted fracture. The unicondylar fractures again subclassified by the Weiss and Hastings into the 4 subcategories, and Hastings stated that the unicondylar fractures are highly unstable and they should be treated with the either close or open reduction, and they cannot should not be conserved. As I said, metacarpal, phalangeal sharp fractures can be treated with K wires. If the transfers, again the technique of K wire can be antegrade, retrograde, or the cross pinning. Here, a example of spiral oblique fracture, which is treated by the interfragmentary screw, and another case which is treated by the open reduction and plating, phalangeal fracture. The condylar fracture are inherently unstable, and they should be treated with close or open reduction and fixed with either K wire or screws. Here are 2 examples. The first one is a bicondylar fracture, which is treated by the multiple small K wires, 0.8 millimeter. The second example treated by the interfragmentary screws, and you can see the articular congruity is maintained. The PIP fracture dislocations are very common injuries because of the cricket ball.
Satish, I'm sorry to interrupt, but you need to keep to the time, please.
Sorry, sir.
Please keep to the time. You're overshooting the time.
Yes, sir, yes. The PIP fracture dislocations are very common injuries and often mismanaged by the initial treatment. They are classified into the 3 types. Type 1 is a hyperextension injury, type 2 are the dorsal dislocation, and type 3 is a fracture dislocation. Fracture dislocation, depending on the involvement of articular surface, they are classified into whether they are stable or unstable. After reduction, one should look for the V side On the check X-ray, if V sign is present, that means the joint is still subluxated and it needs a further correction. Most of the PIP fracture dislocation can be treated only in the extension block split. The PIP joint should be kept in the flexion if the fracture is stable in the flexion arc of motion. Though for unstable and irreducible fractures, open reduction is the treatment of choice. We use the shotgun approach. We open the joint like a shotgun. We fix the fragment with IFS screws. If the fracture is stable, the dynamic external fixator can be used. We commonly use nowadays Suzuki fixator. With the chronic injuries that come later, or chronic injuries that are not amenable for the primary fixation, the volar plate interposition or the hemi-hamate arthroplasty are the other alternatives. Saying that the hand fractures can be complicated by deformity from no treatment, stiffness from over treatment, and both deformity and stiffness for the over treatment. One should always keep in mind this statement by the Swenson, which aptly stated for the hand fractures. Thank you, sir.
Yes, sir. It was a very informative and breathtaking lecture, actually. You covered a lot of things about the phalanx and other things, including the trauma and to the plastic. And common is the jersey finger and other things. It was a very elaborative lecture. I hand over to the Abhijit, sir.
Thank you, sir.
Thank you very much. Thank you, Satish, for a very crisp talk. And I think the last slide was very important when you said that hand fractures can be compromised or can be complicated by over treatment, under treatment, or no treatment for that matter.
Yes, sir.
The most important message that perhaps one should take away from this talk is that most of the hand fractures can be treated non-operatively. And the rehabilitation is of paramount importance in restoring hand function. In our country, I think cricket, which plays such a dominant role in our lives, results in a lot of hand injuries, especially the PIP fracture dislocations. And one of the most important messages that we should communicate with our colleagues is that these injuries should not be treated in extension, however, in flexion with an extension block splint or an extension block pinning for that matter. And a large majority of these injuries at the get-go will be appropriately dealt with if we just avoid splinting and extension. There are some injuries that may not still be reducible or will still have some subluxation and flexion. And these are injuries that qualify for surgery or late presenting injuries for that matter. And then transverse fractures of the phalanges are extremely unstable fractures, and they should be recognized and dealt with appropriately. They usually require fixation and cross-pinning or plating or using some kind of an internal fixation device at times will be beneficial to deal with these fractures. So thank you very much, Satish, for a wonderful talk. It was very crisp. Again, a topic that needs more time, I believe. But thank you for covering the basics in terms of diagnosis, identification of the injuries, and treating with them in a very succinct manner. I now call upon our next speaker, Dr. Daravde, who is going to speak to us on basic considerations in nerve injuries. So we are trying to cover the basic tenets of hand injuries in terms of distal wrist fractures such as distal radius, carpal fractures, hand fractures, and now nerve injuries, which can also be very commonly seen in clinical practice. Dr. Daravde, over to you. Thank you very much.
Hello, am I audible?
Yes, you are. Yes, you are. Thank you.
Okay. Good afternoon, everyone. I would like to start by thanking Dr. Vaigaonkar and Pune Orthopaedic Society for having me here. So I'm trying to cover the traumatic lacerations of peripheral nerves and upper limbs and common compression neuropathies, mainly the carpal tunnel and cubital tunnel in a short span. So we'll have to rush about a few points. So jumping right into a clinical situation where we are suspecting a peripheral nerve injury and assuming that we are looking at a patient who is hemodynamically stable, what are the concerns when it comes to assessing for the nerve injury? So as a surgeon, the first thing I like to know is what is the potential mechanism due to which we are suspecting a nerve injury. It could be a crush injury, machine crush injury, which looks ghastly, such as this, or it could be a little innocuous looking injury. This is a stab wound because of a sharp piece of glass. And this has implications about these injuries. The second thing I do like to know is, are we looking at an acute situation, a subacute, or a chronic situation? And a rough point line between acute and subacute would be around 5 to 7 days. So as long as I'm looking at a patient within the first week, I'm hoping for a primary end-to-end repair if it is divided indeed. Anything beyond 1 week, things start getting tough. And anything beyond 3 weeks, I think we should plan for some gap and think about how to bridge that gap. The common way to approach any nerve injury is obviously the sensory and motor evaluation. And commonly what I see is we tend to go for the autonomous zone of the nerve that we are suspecting to be injured and ask the patient to feel the light touch. It could be with your fingertip or a cotton wig. And the common question asked is, do you feel this? And if there is a complete transection of the nerve, and we are looking in the autonomous zone, then probably this is an appropriate question and you will get a good answer. But in compression neuropathies or in partial nerve injuries, this is not the best question to ask. The best question to ask is, how much do you feel? So a good way of going about it, this is, suppose I'm suspecting a radial nerve injury in the right side, then I'll go on the back of the first web space on the left side, touch him there, assuming it is uninjured, and tell him this is 10 on 10. And now let's go to the injured side and then ask him, do you feel this and how much do you feel? Is it 10 on 10 or is it less than that? And this way we are unlikely to miss any hypoesthesias, which especially happen in compressive neuropathies. It will be very, very late when you get an anesthesia in a compression neuropathy. So a better way of going about would be, how much do you feel? Motor evaluation is useful, but in acute situation, pain may be a trouble. So if patient has a sharp injury to his entire volar forearm, you can't really expect him to move the muscles even if they are not injured. So in acute situation, there is a trouble there. And then there are some small fallacies which we'll talk about in a moment. This is one nice little fact to know. It may not be always useful, but if we are looking at an unconscious patient or a child who is not going to cooperate with sensory or motor evaluation, then the response of the skin to a wet environment can give us a clue whether that particular skin is sensitive or not. So let's say we are looking at a digital nerve injury, one-sided digital nerve injury. And if that part is submerged in water, or we do submerge it in water, then the part which is insensate will maintain its skin turgor. And the part which is sensate will wrinkle, as we see when we take a swim or we take a long bath or something. Tinel sign is an extremely useful clinical situation, clinical sign, and there is literature which tells us that you can get a positive Tinels within 24 hours of injury, and that there itself gives you an idea about the classification of injury. So, and Tinels present will tells you it is grade 2 or more severe injury, whether we follow the Seddon's classification or Sutherland's classification. So those are about the clinical examinations. If any residents are watching, these are a few small things that I like to call as the small tricks in examination. So if you are looking at an ulnar nerve palsy, like in this case, the examiner's hand should be in same position as the patient's hand, and when we are assessing non-dominant hand, then we also should be using our non-dominant hand. If we use a power grip, then we can pull out the paper from any grasp of the patient. So this is especially relevant for trainees if they are attending. And another common problem that I have with missed radial nerve or posterior interosseous nerve injuries is the interphalangeal extension is sometimes mistaken for intact posterior interosseous or radial nerve function. So the key basic fact to remember is the long extensors supplied by posterior interosseous or radial nerve primarily extend a MCP joint. So if the patient can lift his fingers off a flat surface like in this, the posterior interosseous is working. But if he can't do that, then probably we are looking, the interphalangeal extension that we see is only because of the intrinsics, and we are looking at a potential radial or posterior interosseous nerve injury. So a common simple protocol that we can follow when we are assessing nerve injuries is, the first thing is there a wound over the course of the nerve? Surgeon has to be well versed with the surface markings for the course of the nerve. If the wound is absent, whether there is a fracture or not, the general inclination is towards conserving such an injury. Mostly we all encounter this kind of situation in humerus fractures with radial nerve palsy. Specific to that situation, there are around 10 to 12% of humerus fractures associated with radial nerve palsy, and amongst them around 10% have actual lacerations. So 90% of the people can get away with a conservative management of humerus fractures, even with a radial nerve palsy, because it is expected to recover. That being said, if we are really concerned about the continuity of the nerve, a skilled sonologist can give us a pretty good idea whether the nerve continuity is maintained or not. And exploration is not the norm, but exploration is in specific situations, especially when it comes to humerus fractures. If I can elicit a tinnitus, a profound tinnitus with a dense muscle weakness, muscle palsy distally, and no complete anesthesia, then that would be a situation where I would start wondering, is there a physical injury to the nerve more than grade 1? Whereas if there is a wound over the course of the nerve, then exploration should be the norm, no matter what the wound appears. And if the surgeon decides not to explore, there has to be very strong clinical evidence of integrity. The sensations have to be perfect. The motor power has to be more than 4 at least. There might be a component of pain inhibiting the motor function. So the norm should be exploration rather than conservative line of management. So let's look at the examples we have seen before. And this is the wound which it looks, the temptation is to give some 3-4 cc of lignocaine and gives 2-3 stitches, and that's the end of it. But this wound overlies the course of the median nerve, and when we explore, this is what we find. So what you see here is so that's the torn FCR. That's the proximal end of the median nerve and distal end of the median nerve, and the FPR was gone also. And then we ended up repairing this. A point I would like to say here is nerve repairs should be attempted with as fine material as possible. Most of the hand surgeon community will use anything between 8-0 to 10-0 while attempting to repair the nerves. And the logic behind this is, the bigger the needle, even if it's a 5-0, it will cause more trauma to the fascicles and more fibrosis in the nerve and poorer results. And this cannot be done without a magnification. So magnification is a very crucial part. Look at the more ghastly looking wound. Actually, I was wondering whether how the index finger is surviving, because it looked like everything must be gone inside. And what we found is everything was gone except for the digital nerves and digital arteries. So the appearance of the wound has no bearing as to what injury the soft tissue structures inside might suffer. So it needs a very thorough evaluation and high degree of suspicion. I would rather explore and come back with an intact nerve rather than miss an injury to the nerve. So this is another example. This was a chronic injury, and this is one small thing that I would like to tell. If we are evaluating for chronic nerve injuries, it is very easy to see that the nerve looks to be in continuity and just get rid of the fibrosis around it and it might regenerate. But that is a little fallacious evaluation. And you see the nerve ends, these ends came apart just by blunt dissection. I didn't even cut them. The ends look totally fibrotic. And if you just keep this nerve in situ the way it was, it will never recover, and we'll keep on wondering why it didn't recover. For a nerve to heal, it needs to have a cut end that looks like this. So what you see here are the small fascicles. I wish I had a more magnified image of the same, but I guess we can all appreciate it. Another thing I would like to highlight in this picture is, can you appreciate this small blood vessel that is traveling on the surface of the proximal end? So this fascicular structure and these fine blood vessels tell us the rotational alignment of the proximal and distal cut ends. And obviously you need magnification for that. But with these two guidelines, we can hope to get the proximal motor end to a distal motor end and not get a cross connection between a motor and sensory end. And that would obviously lead to a poorer outcome. Obviously, this was a chronic injury, so there was no hope of primary repair. So we ended up using cable grafts with some nerve glue, and that's how we repaired the nerve. This image I have just put because I wanted to highlight how fallacious children's injuries could be. So it looked like a very superficial wound. I have to confess that I was also hoping that there is not much injury there. I just debride and see what is going on. But we ended up finding a lot of things damaged, one of them being the median nerve, as you can see here. So that's about the nerve injuries. Briefly covering the carpal tunnel and cubital tunnel. So when we see the patients of compression neuropathies as clinicians, obviously you want to know the first history. So you want to know how long the symptoms have been going on, and accordingly, even before you actually touch the patient, you can get an idea as to what kind of findings could be there. Another pitfall we should be avoiding is simultaneous compressive neuropathy higher up in the cervical spine. That is, you can do a Sperling's test to evaluate for the same. And the point here I'm trying to make is if there is a proximal neuropathy because of the cervical spine, and we don't recognize that and we decompress the distal part, and the symptoms are not totally relieved, then it is harder to explain to the patient what has been going on. But if we pick it up earlier, the plan is still decompressing the distal neuropathy and see what is going on. But then the patient is in sync with our plan and we have no problems. There are various clinical tests. You can divide them broadly into provocative test. It could be a phalanx or reverse phalanx for a median nerve in carpal tunnel, or you can have a cubital tunnel provocative test where you just simply flex the elbow as much as it goes into flexion and press proximal to the cubital tunnel, and that should recreate the symptoms. Tinel sign is very useful to localize where the potential compression site might be. I tend to find that positive Tinel sign is relatively a bit uncommon in carpal tunnel, but in cubital tunnel, most of the patients you can elicit a good Tinels. It is good to cross-check with the opposite side and see whether that tingling sensation is because of a compression or it happens because of the superficial nature of the ulnar nerve. And there is another interesting test described in US by Dr. Susan McKinnon. For the brevity of time, we can't go into details of this, but it is a very useful test which you can use for all the compressive neuropathies. There are 4 or 5 sites in the upper limb which have been described, and this is a nice test to corroborate with the other tests. The role for nerve conduction tests is, especially when I'm planning a surgery, that is the time when I do by and large a nerve conduction testing. I feel that this is the only objective clinical evidence that you can have. Otherwise, it is all just a subjective evaluation. Or if there is some degree of confusion that is going on as to exactly what is happening there, then the NCV can come to our rescue. This is one paper which compares different tests for, especially for carpal tunnel. And what I would like to point to is none of the tests are even 90% sensitive. The Durkins and phalanx are maximally sensitive. So if we try and combine all the tests to evaluate the patient, then we can get a better picture, because even 30% of carpal tunnel syndrome patients will have a negative phalanx. So this is where all the other tests come into play, like scratch collapse test. So few brief points about carpal tunnel syndrome. I think we are all aware of the symptomatology. Nocturnal paresthesias are virtually clinching in the diagnosis. Classic territory of radial 3.5 digits is not always found. It is quite common to have all 5 fingers having paresthesias. If it is so, then I just look carefully at the Guyon's canal and the cubital tunnel just to make sure that there is no simultaneous ulnar neuropathy. But I think a lot of times the patients do attribute a classical carpal tunnel to all 5 fingers also. As long as the sensory symptoms are predominant, there is a role of conservative management, but presence of motor symptoms certainly push us towards the surgical management. This is one of the few patients who came very late for carpal tunnel and has lost her thumb abduction. There is a small point about recurrent motor branch. So if you find a patient who looks like a carpal tunnel, but he has a significant component of pain in the thenar region, or there is a very early onset of thumb movement loss. Think of a recurrent motor branch, which might be independently compressed, and we have to look for it while decompressing the normal carpal tunnel. I think all of us are versed with conservative line of management. The only thing I would like to highlight here is when we immobilize for carpal tunnels, the wrist should be in neutral position and not in dorsiflexion as we are used to doing. A small point about carpal tunnel release. This image shows the palmocutaneous branch of the median nerve. On the left side is the thumb, on the right side is the little finger. And this is the nerve that you want to protect while you are doing a decompression. That is what plants the markings of the incision. So a good way of going about that is if you radially abduct the thumb and draw a line along its ulnar border, then the line you get is the cardinal line of Kaplan, and this essentially marks the end of the carpal tunnel. So beyond this, very close by is the fat pad tissue, in which there will be palmar arch, which are the origin sites for the digital arteries. So we certainly don't want to end up going there and injuring them. So our endpoint we know on the skin that is here. And to avoid damage to the palmocutaneous branch, the second line that we use is the long axis of the ring finger. As long as our incision is on this line or ulnar to it, we are definitely away from the palmocutaneous branch. So this is the site of incision. With sir's permission, I'll run a very short video as to how we release. I have a disclaimer to make. These are not my videos. This is I should shoot one, but this is the same technique that I try to follow. So the incision is, as we said, the stretching of the skin helps in getting to the deep tissues. And a point I would like to make here is sometimes the longitudinal fibers of palmaris longus can be confusing. So you have to look at the facial fibers, their orientation. The carpal ligament fibers would be transversely running as in here. And the palmaris longus insertion fibers, the palmar fascia, will be longitudinally oriented. So that might be a small issue, especially if you're not used to doing this surgery. I like to make one small incision, and then if needed, we can push in some mosquito underneath. And this is the critical step. So this is the distal end. And the moment you see this fatty pad that has come into play, you know that we have reached to the distal extent, and that's the end of distal release. And now we have to move towards the distal end of the patient. And we need a good assistant, especially if you want to do this without crossing the wrist crease, and pull on that carpal ligament and the proximal thick antebrachial fascia and divide it under vision. Doing a blind sliding of the Caesar is very risky and possibly can injure the median nerve underneath. So should be avoided. There is no shame in just simply crossing the wrist, getting a good look at everything, and try avoiding injury to the median nerve. Just briefly touching on the cubital tunnel, I think the provocative test we have already spoken about. There are, I think everybody knows how to decompress the cubital tunnel. There are multiple ways wherein if you want to transpose it, the way you transpose this is the technique that I do like. I don't know, and I'm sure that there will be different techniques across the board in this group itself. But what this technique does is raise two flaps, one based medially, one based laterally, from the mass of the flexor pronator mass proximal tendinous tissue, and create a loose sling out of these two to keep our ulnar nerve underneath. So for brevity of time, I've speeded up the video, but the end result looks something like this. So you see how loose that space is in the ulnar for the new root of the ulnar nerve. At the same time, that medial flap will make sure that it doesn't translocate back to its original pose, and it lies very nicely and straight with the elbow range of motion. Thank you. Thank you.
Nilesh, it was a very presentation. We are happy to see the various tests you showed, how to do clinically with the perfection, and the various methods and proper techniques of surgery that has covered your talk. So I hand over this mic to again Vaigavkar sir. Thank you.
Thank you very much. Dr. Nilesh, you must be wondering why we kept your talk towards the end, because we like to keep the best for the last.
Thanks.
That talk of
I can also say, sir, our focus is on bones, so maximum people, who saw it is bones. Nerves can come later.
Yeah, I think you've done great justice to this talk. You have brought out the fine nuances of peripheral nerve injury and compression neurology to keep away from the nerves. We were always shy of the nerves. And why should we be so scared of the nerves? We should learn to handle the nerves under circumstance. So I think understanding nerve, handling nerve injuries, the anatomy is paramount to performing good surgery. Colleagues and our peers could also start recognizing that nerves are something that you need not be scared of. And I think at the beginning, you can collaborate with a colleague who is well versed in peripheral nerve surgery and learn the nuances to do the primary, kind of uh, because Kedar Jagtap, could you please mute your video? Thank you. So I think it's important that people start recognizing this injury pattern and deal with it at least in the periphery, and using the fine instruments. It's a very basic set. So microsurgery instruments are not very expensive, and learning to use some magnification or using finer suture materials can save you from a lot of complications. So I think that was a fantastic take on peripheral nerve injuries. Thank you very much. And with this webinar, I would like to, tell our colleagues and our members of the POS that if you don't reach out to us and be involved, we are going to come after you and rope you in for webinars. We want to hear from you. We want to learn from each other. We want to, include everyone in our journey of learning. And I think the best way to learn is to teach. Um, the younger generation especially needs a platform, needs to speak out. There are so many people who are coming with such fantastic training, and the POS would really like to partner with you in your success story. And I really want to thank everyone today for this fantastic webinar, for participating at such a short notice. We just decided to kickstart this, and more so Ashok Sham sir. I think I just told him a couple of days ago, and until the very last moment, we were improvising on the organization of the webinar. Thank you, Ashok Sham sir. And I think, do we have some time for any case discussions? That would be a great idea to just discuss one or two cases. Yogesh, do you have anything that you would like to share with us?
Yeah, I can share. I collected some cases that will be post-op cases or pre-op cases. We can have a short discussion on that if time permits. I think it's almost 3 o'clock. Can we have one or two cases, or at least we can have some discussion?
Ashok Sham sir, can we have one case, one or two cases for discussion, please, very quickly?
Yes, please go ahead.
Thank you very much. Thank you so much. Yogesh, I request you to please share your screen. And
I will share my screen. I'll just show some cases, and let us have one good discussion or some modification in treatment part also.
And I want the faculty to be involved in this. I'm going to put myself on mute. Yogesh, I request you to please share your screen and then pose the questions to the faculty. Thank you.
Select files. Okay, it's not a basic thing.
Share your screen, please, Yogesh.
Yeah, just sharing the screen. Actually, I'm getting my file. Wait a minute. Wait a minute. Let me share my screen. Wait a minute.
It should be at the bottom of your screen right now.
Yeah.
I can.
Yeah, I'm sharing the screen, but I'm not getting my PPT actually. Where is the PPT?
Open your PPT first and then share the screen so that it will show up on your screen sharing options.
Okay.
So while he's getting his screen up, a very quick recap about today's talks. The first talk was by Dr. Anup Bansode about distal radius fractures, something that is very commonly seen in clinical practice. Please get proper X-rays, especially traction views if your patient is unable to afford a CT scan. Know the implants. Please be careful about the choice of implants. Do not cross the watershed line if your implant is not designed to cross the watershed line. And also recognize the fracture patterns, the columns, the nitty-gritties of the fracture patterns, and then deal with appropriately. The second talk was about wrist fractures. Again, it was an exhaustive talk, but very well covered by Dr. Shailesh Patil. Remember scaphoid fractures and transcaphoid perilunate fracture pattern injuries. Other fractures may be a little uncommon, but hook of hamate fractures can be pretty deceptively be missed. So keep an eye on that. Satish's talk on hand fractures was pretty lucid. Thank you, Satish, for it. Keep an eye for PIP fracture dislocations, and keep an eye out for rotational deformities. And I think the nerve injury was perhaps the cream of the webinar today. Thank you very much. Over to you, Yogesh.
Yeah, this is an actually, there are a few cases which I don't have any long-term follow-up. Sometimes follow-up is missed because I'm attached to Diva Patil also, medical college. So let us see. So this is an phalanx fracture. So any takeoff on this post-op X-ray? Can anybody comment on this?
Yeah, the fracture.
Yeah, please.
No, I was asking Dr. Anup or Dr. Satish to comment.
Anup or Shailesh, they can comment. Usually we do proximal and we go joint below and above for external fixation, actually, Jess. But I opted for this. Yeah.
For me, I think the idea of not crossing the metacarpophalangeal joint is great one because it is very if you want to immobilize metacarpophalangeal, it needs to be immobilized in flexion.
Right.
That's very hard to achieve with a just fixator.
Right.
Under the right circumstances, I would think about internal fixation for this, looking at the comminution.
Okay.
But then the cost factor comes in.
You want to add K-wires in this fixation or what?
Yeah, so my if everything else is right, I might actually think of an open reduction and plating so as to bridge that comminuted fragment, because fortunately the base seems to be in good shape, so we can get some good hold over there.
Right.
The length, even if you get it on day one with some soft tissue collapse, eventually there are some deformities. And you can't get 2 wires also, so that could also lead up to deformities.
Right.
That's my take on it, but
yeah. Anyone else want to take on this?
So basically, I would like to share that I would like to see the true lateral X-ray, as both X-rays are not showing the true lateral X-rays.
I have this, but believe it, it's a good alignment in lateral X-ray also.
Yeah, then I think I will accept. I will see. Yeah, if clinically patient is able to flex the complete fist and there is no rotational alignment, I will accept this, and it's a nice fixation. I will
Actually,
say.
the idea behind this was that, as correctly mentioned by the previous speaker, that there is usually I've seen the stiffness over the MCP and other joints. So it's better to have the mobility of the joints with this limited fixation. And we are planning to keep this at least 3 to 4 weeks. If, as mentioned previously, it may have displacement also. So we'll keep watch on this after 3 weeks. And if needed, we will intervene with open reduction and internal fixation. So again, yeah, please, sir.
I just want to make a point, and that's something which is very important that everyone recognizes. Never ever treat a phalangeal or a metacarpal fracture without a lateral view. And even in the follow-up, please take a proper lateral. There should be 3 views: posterior, anterior, the oblique view, and the lateral view. So that's something which is very important. And I understand that they may not be available at times when you're working in a
Yeah, but
public.
yeah, it's a two lateral is been taken, dead lateral was taken. It has
No,
well
no,
aligned height is
I'm not
length.
saying about this particular presentation or discussion. I'm just talking, I'm
Yes,
saying as a general point that everyone should remember, because a lot of times we just tend, or the technicians are not aware of this. So you need to call up the technician and tell them that I also need a true lateral view.
so again, the same thing. It has been tried, but this will keep the follow-up of 7 day, because then if you see in oblique view, there is a gap at this point. So we are planning actually open reduction and internal fixation with interfrac afterwards. But temporary, it has been fixed like this to have callus, and let us see whether we can maintain this and whether it has healing. That's the thing we have done this. Any comment on this?
Can I say something, sir?
Please.
For this case, I will go the small K wires, percute K wires, perpendicular to the fracture line. And additionally, I will immobilize with the external fixator as you applied.
You're right.
So for me, this I will do the K wire perpendicular to the fracture line, and in addition, JS fixator.
Yes. Next time I will put the follow-up of this also next sessions. So
Yes,
this
sir,
is the idea behind it. Now about this distal and radius fracture. So comminuted distal and ulna with rotation, and interarticular distal and fracture with split and proximal extension. Can anybody can plan the line of fixation or a treatment plan? Open to all.
Did we do a CT? Or?
No, CT is not. He was not affording, sir. That's the reason.
Affording,
I
not
just
okay.
saw the X-ray. I inform about the CT, but the patient was not affording. That's the reason.
Yeah. So
First thing after seeing the X-ray, I opted for the CT.
If it's possible, I would like to get that, because the comminution may be underappreciated on plain X-rays.
Right.
But yeah, that's the reality we have, that not everybody can get CT and fancy
Yeah.
implants also.
Suppose we are working at the periphery, you don't have CT, then what to do? Like that.
Yeah, correct. I agree.
Yeah, sir.
Traction view.
Sir, luckily I could not take traction view on this.
No,
But
well, the point I'm trying to make is that,
yeah,
we hear this so often. My patient was not able to afford. We didn't have a CT scan available. So if all of this is not available, at least take traction views. And the traction view should be taken in the PA, the lateral, as well as the anterior-posterior kind of rotation. So it just takes gentle traction. You can do it with hematoma block. You can do it with the patient being relaxed, and then just gentle traction and take a traction. You need not apply too much of traction.
yeah. It's a very nice idea.
All that you're trying to do is get, not in this particular X-ray, I won't be too worried about the displacement, but there are certain dorsally displaced or volally displaced, kind of Barton variants where the X-rays look very intimidating, the preliminary X-rays. And then when you take traction views, the fragment just start falling back in place. And even in the absence or in the situation where you can't get CT scans, they can augment your understanding of the injury pattern quite a bit. So just
The purpose of putting this X-ray was this only. See, if you don't have CT scan and you get such a type of picture, then what to do? The senior persons like you can guide us, and it is a very good suggestion that hematoma block, and under hematoma block with gentle traction, we can have also oblique views also, so that we can get 3D orientation of this type of fracture. Now the thing is that we don't have the CT and we have to plan. Then what to be done for the distant radius and separately for the ulna? So what will be the plan? What should be the line of fixation?
Anyone from the panelists?
Yeah, speakers.
Yeah, I'd like to go for, say, molar plating for the distal radius, because this lunate fossa is involved. You can see here. And the ulna, again, after fixing radius, if it is,
about the ulna.
yeah, after fixing the radius, we'll see the stability. And depending on the stability, it's better to put a plate, mini plate.
Mini plate. Okay, you want to opt for
Yeah.
the mini plate. Yeah. Any others?
Yes.
Any other method as suggestion?
Or we can go for nail plus radioulnar wire.
All right.
But
I would keep some wrist spanning option ready in the theater.
Right.
Because if you don't have CT, sometimes
Yeah.
what happens is just beneath the articular surface of the distal radius, if you don't have enough bone to hold on,
Right.
then we land in a quandary as to how to stabilize it.
Right. Right.
So if we feel on table, we can always bridge. And in this case, suppose I would probably put a spanning option both on the radial aspect and on the ulnar aspect, and hopefully that does the trick. I'm not saying that's the best option, but I think that should be there as a standby on table.
Yeah. Any other option or any other method? Please, sir.
So this X-ray, one might be very tempted to think that the radius is not the issue and perhaps the ulna is. But like Shailesh rightly mentioned, that there is a very long oblique fracture of the metaphyseal, diaphyseal, and extending into the joint, perhaps ulnar column fracture, the ulnar corner of the radius. That should be addressed, and you could do that with either a proper volar plate, or you could use just an ulnar sided plate in a buttressed manner, or maybe use a proper volar plate. And once you have fixed the distal radius, you would turn your attention to the ulna. And these ulnar fractures are a huge challenge.
Yes, sir.
They should not be taken lightly.
Right.
And getting the DRUJ in alignment and maintaining the length of the ulna is paramount, of paramount importance. There are several plates that are available these days, something called as the ulnar hook plate. So the hooks or the tines of the plate, they sit onto the styloid, and then you can span the ulna and then fix it. However, in this particular fracture, perhaps you may even need a bone graft. Looking at the combination, we know that the distal fragment doesn't have much of a purchase it does not provide for a good purchase in the distal fragment. But yes, there are multiple ways you could deal with this. Like Dr. Daraude said, you could use a spanning kind of a distraction reduction kind of a device to hold it. But provided that you also use something to fix the ulna primarily, so that your reduction and maintaining that reduction is facilitated. Thank you.
Yes, sir. After talking to the patient, we have planned for the volar plating of the radius and the spanning of the ulnas as mentioned by you people. And we have informed that in future he may need SOS ulnar plate fixation. So this is just done yesterday. So I tried to get this. The maximum possible spanning and alignment I could maintain is this. You can see there is a DRG wire tried to maintain. This is not actually through the joint. I checked in a proper AP view. It's subchondral actually. It's not in a joint. And this is the spanning with what we maintain. Luckily, 2 interfrag have done is a fabulous job. It has a good fixation. And we are planning to have serial X-rays after 3 weeks and also 5 weeks. And if fracture gets gummy, we may plate again. We are informed to the patient also. I may need bone graft and plating in future. But we are trying to see with X-fix and spanning, can we maintain this ulna? So any other method or any other fixation you want to suggest? Yes, sir.
One of our senior members and colleagues, Dr. Sarunke sir, also has a very interesting and a very novel technique to deal with distal radius fractures, wherein he passes a radioulnar wire and uses that incorporated into a cast, so it maintains the length.
Right, sir.
It might be interesting to perhaps consider that technique. He had presented it once at the POS and had won the best paper award for it. So that's one technique that may be useful in this particular scenario, provided you know how to use that technique.
Right, sir. Right, sir. Thank you. And just to discuss the things, these are routine cases. And any comment on post-op? Or you want to add something regarding ulnar styloid? There is a lot of confusion about the ulnar styloid fixation and other things. Vaigakar, sir. Can you little bit elaborate us on this?
Let's go to the pre-op and discuss the pre-op. I would like to ask Dr. Nilesh Daravde to please read the X-ray for us and tell us a little bit more than what is seen.
Yeah, so based on the X-ray, I'm not sure whether there's a radiocarpal extension on the of the fracture, but it looks like a Smith kind of a fracture. And the primary problem again would be the shortening of the radius. The ulnar styloid fracture is a little borderline. If it was a little more proximal, I would be very worried about it. At this point, I'm thinking maybe TFCC stability should not be an issue. I would like to go to the other side, check the stability, and then interop once my radius job is done. Then I can compare it with this side and then decide whether to do something to the ulnar styloid or not. If possible, I would get some other views to look for a radiocarpal articular surface if there is a fracture extension into that. If this was a fresh injury, then I think it should reduce well. If it's an yeah, so if it's sometimes if it is old and you struggle to get reduction, brachial stenotomy actually does a lot of help to get the reduction back. That's my thought.
From the radiological point of view, so just to kind of look at the X-rays more objectively and to kind of take away some points from Anup Bansode's talk. So we can see that there is loss of radial height. So there is so every X-ray that we look at, we should try to corroborate the findings and try to fit them in something called as the LaFontaine criteria and the Stewart scope to determine the risk of instability of these fractures. So if you look at the posterior anterior view for that matter, there is shortening of more than 10 millimeters, 5 millimeters. So that kind of is one risk factor. There is a fracture of the ulnar styloid. There is also some comminution. I'm not too sure, but I suspect that there is a separate radial styloid fragment and there is a separate intermediate column fragment. If you look at the lateral view, there is an increase in the teardrop with some, kind of, like you said, a Smith's variant of the fracture. And therefore, there may be a risk of collapse in the long run. So this is something that needs to be fixed in a more definitive manner. And I would consider, of course, open reduction internal fixation. I can see that he's a 28-year-old male. Even though it's a non-dominant side, I would want to rehabilitate him at the earliest possible. So I would go ahead and fix the fracture first with volar plate and then assess the DRUJ instability in 3 rotations: pronation, supination, and in mid-prone position. A lot of times the ulnar styloid does not require any fixation. If I find that the DRUJ is stable in supination and in a little bit of mid-prone, but is unstable in pronation, I would just immobilize in an above elbow splint or a cast for about 6 weeks with the forearm in supination. However, if the DRUJ is unstable in supination as well, you need to address that problem. And that can be done with multiple different modalities. And I think we discussed quite a bit of this on the trauma POS group, WhatsApp group. So we'll not belabor too much on that right now. So Yogesh,
actually it was a stable DRUJ at that time. So we didn't fix and opt anything for the ulnar styloid. And we have given a slab for a supination in a 3 weeks above elbow slab. Okay. Yes. And this is another case. Just I'm sharing the post-op cases, not much in the routine cases. Anything you want to add on this?
Was there a previous ulnar side injury? Or?
It was there. There was a previous old injury, but it was very old injury, almost 5 to 6 years old.
Yeah, so
and it was a stable. DRUJ was stable.
Yeah, I would expect maybe a little loss of rotational movement. It's happened to me once. I fixed one radius. I thought I did a decent job, and then the rotations were restricted. And then after surgery, we asked the patient and he told, yes, I had a previous injury on the ulnar side. I guess that might happen in this situation, but otherwise, it looks a good job.
The case is to just initiate the discussion and add something to it. This is a little bit proximal extension. It was an unstable DRUJ, and we had a discussion on WhatsApp group also about the DRUJ wire, K-wire.
Yeah.
Vaigakar sir is not in that much favor of wire, but
yeah, but if you have to place one, my suggestion is to go a little more proximal.
Proximal.
So to immobilize DRUJ, we don't have to go through the DRUJ. If we are extra articular, it achieves the purpose. And if I have to do one, I like to get my wire out of the radius on the opposite side also.
You're
so
right.
If you are extremely unlucky and patient rotates and the wire breaks, you can take out the two pieces from small incisions on either side.
Right.
Not struggle with completely opening everything up. So that's one small suggestion that I have. Otherwise, it looks nice actually.
And when your instruments are not working, your drills are not working, you land up in such thing. Just to share with the forum and the people who are seeing this presentation, you can land up in this scenario. This was a very bad day for me. There was no drill, nothing. But I could get out with this. He came for the follow-up. Afterwards, I will put an X-ray next time. Luckily, it is remodeling. But this is just to show that you can also fail someday. So you have to prepare with all instrumentations and everything. Even though you prepare for two things, there's a third thing I think we need to keep it. So this is X-ray just shared for this. Then again, this is an injury where 150 kg, 1.5 ton, job was had a fall on the hand, and he immediately came to the hospital with this picture. Oh, sorry. So this was a presentation.
Okay.
Actually, I had a video. I could not put the video. It was an thoroughly crushed injury. It's a crush injury with 150 kg.
Can you share the pre-op X-ray, sir, please?
Luckily, wait, I just forgot. I think I forgot to put the X-ray. Wait. No. Luckily, pre-op X-ray was. I could not put it. I just forgot to put it. This is a post-op X-ray. What I had done. There was. I will give you clinically. There was no. There was thorough debridement of wash was given. There was no sensory deficit. Luckily, there was no vascular thing which I got. And luckily, with this scenario also, there were tendons were intact. They were not crushed. The guy was very lucky, but the scenario was to put the bone in alignment. Though it looks very critical injury, the bony alignment I try to maintain. And this is the actually post-op X-ray. And you can see I tried to put this wire because I was not getting the proper alignment and I was not able to maintain this length of this phalanx. So what I did, I put this wire and bended it and put in this another opposite, this fifth fingers just fixators wire. And we tried to maintain the traction with this method. So probably in future, we are going to do these techniques. So any comment or any suggestion or any modification on this technique?
I'm sorry, I was logged out. My internet connection had switched off, so I'm back again. Sorry.
This is the last, I think, this is the last case what we just discussed. I just want to have opinion with the house.
Dr. Yogesh, I will prefer the axial K-wire in the ring finger.
Okay.
And the
little finger is very difficult to make out.
Yeah. So if there is a articular shattering in the PIP joint, I sometimes feel it is reasonable to straight away arthrodese the injured joint, because sometimes it is just heading there anyways. Once we are done with this, it might still become a painful pseudoarthrosis. So, but I can't really make out well here.
Yeah, I will post the next session. I will post the X-rays. Actually, luckily, I got the good follow-up, and it was very nicely healed wound. But the condition of the fingers and bony things, which will be taken on this next follow-up X-ray. So let us see how it happens, and I will share these things in next session.
What about skin? Have you grafted anything?
No. Luckily, I could manage with the proper closure. There was no need of any grafting, and there was no need of any tendon repair at that time. Even vascular things were surprisingly very normal, even if it was 150 kg.
And you are lucky because looking at the skin,
skin is very good. Skin is good. I'm just waiting for his follow-up X-ray so that I can post in next session. That I will post in next session. I'm just now worried about and concerned about the bony things, not about the vascular and other skin and other things. Okay, Vayoga sir, can we stop here?
Yeah, sure. I think we have pretty much crossed our time by quite a bit. I really thank everyone from the panelists who have contributed of their time and energy on a Sunday. Thank you very much for making this webinar a very interesting one, covering the basic topics. I just want to announce a couple of announcements. We'll be having a webinar towards the end of the month. We'll announce it very soon. Again, on hand surgery, and this will be a little bit of an advanced or maybe more, kind of complex topics from more senior and experienced surgeons. And again, we'll try and make it as interactive as possible. We want people to kind of contribute and to come forward and collaborate with us on this endeavor. The second is that the announcement is that we are planning to have an academic kind of a calendar, which was actually kickstarted by Shailesh Hadgaonkar, and he did a fantastic webinar series on spine. And POS is very grateful and proud of his accomplishments, and we just want to take the cue. We had a little bit of a lull in between because of a few issues and too many webinars that were going on, especially the IOACon and the MOACon webinars, which took precedence over the POS because quite a bit of our own faculty was involved with these webinars. They had national kind of importance. So we just kind of agreed to lay low a little bit so that we could share the time on a Sunday and find a slot for ourselves. So we'll be more active in the academic sessions right from today. We will be having some non-academic webinars as well, which we will enjoy on the occasion of the great festivities that are coming up on this Dussehra and Diwali. And we will be having webinars based on thematic, kind of a background. So pediatric orthopedics, trauma, arthroplasty, arthroscopy. We'll try to rope in the more experienced seniors and the mentors and the mentees to make this very kind of a inclusive as well as a compelling learning experience for all. Thank you, Ashok Sham sir, for your support at all times, and we look forward to a continued association with you. Thank you, Dr. Nilesh Daravade, for your time. Thank you, Dr. Shailesh Patil, Dr. Anup Bansode, and Dr. Satish, and especially the POS leadership for entrusting me with taking this forward. But let me confess that none of this is possible without teamwork. Dr. Yogesh Khandalkar, you deserve special recognition and thanks and gratitude for standing by us. Thank you very much, and I think we could call it a day. Thank you.
Thank you, sir. Thank you.
Thank you very much.
And Ashok Sham and other all faculties and listeners and viewers who has interested in this webinar. Thank you very much. We are looking forward for great webinars under the leadership of Dr. Karne sir and Vayoga sir in future. So let us be with us and connect with the POS. This is our team. Okay. Thank you. Have a nice day.
Thank you.
Thank you. Thank you.
Stay safe. Bye.